go on. All right. Okay. So the title is going to be Puberty. We're going to talk about different types, and we are going to touch on delayed puberty as well as precocious puberty. So I'm just going to just go over some terms that I think will be helpful in understanding what we mean by bone age, mid-parental height, genetic targets, and that type of thing. And then we'll go into delayed puberty, and then we'll talk a little bit about precocious puberty, okay? Um, so a lot of times we have we talk about mid-parental height. So this is based on mother and father's height, and it's a genetic target. We frequently see referrals where the patient is at the fifth percentile, or even lower, and the family's mid-parental height is also like around the fifth percentile. So they have familial short stature. We would definitely worry more if they are growing at the fifth percentile and the mid-parental height is all the way at the 75th percentile. So we would think about what else could be going on, right? So how do we calculate this? So target height for a female is height of father minus 13 centimeter plus height of mother divided by 2. And the target height for male is height of mom plus 13 centimeters plus the height of father, and then average divided by 2. Um, so if I were to give a genetic target of, say, 64 inches, it's plus or minus 2 standard deviation, which is about 4 inches. So I could give 64 inches plus or minus 4 inches. And if they end up anywhere in that range, they are within their genetic target, right? So mid-parental height is super helpful. I don't think you'll get quizzed on this. Epic actually calculates that out for you if you just enter the parent's height in inches or centimeters. So it's really helpful to plug this in when you're looking at short stature, delayed puberty, to try to figure out, are they doing okay? Are they expected to be meeting the genetic target? And to give more anticipatory guidance to the family. So there are a lot of times we look at this linear growth velocity by age. If I have a patient who's coming in like 11 years of age, 12 years of age, who is certainly pubertal, I'd expect to see a pubertal linear growth velocity. If they're growing, so if it's a boy and he is, say, 12 and a half, and he is 10 or 3 for his testes, and his growth velocity is about 4 centimeter per year or 5 centimeter per year, that is very unusual. Peak growth velocity during puberty for boys should be close to 10 to 14 centimeters per year, and for girls during puberty is about 8 to 12 centimeters per year. On average, girls can expect to gain about 25 centimeter. And don't quote me on this. This is just, it's in the textbooks, but, not everybody's going to get to that. But, 25, and then boys is a little bit higher at like 28, 29 centimeters during that entire pubertal period, which could take 2 to 3 years, right? And I just included the growth velocities for when they're infant to puberty. But first year of life, you can expect to grow about 25 centimeters per year. First to second year of life, it slows down. It's about 10 centimeters per year. Second to fourth year of life, it's 7.5. And then 4 years until puberty for both boys and girls, it's about 5 centimeters per year. So even if you are seeing a patient who's 10 years of age, prepubertal, and growing at 5 centimeter per year, they're doing just great, even if it's the fifth percentile or just under. All right, and then we frequently get bone ages, right? So how is this helpful? So you are seeing a 14-year-old male for delayed puberty, and then we say we need to get a bone age. So bone age gives us an idea of the maturation of bones and exposure to hormones, right? So a chronological age is 14 for this patient, but what is his actual skeletal age? So, say if this bone age was like 12 or 11, that means that even though the chronological age of this patient is 14, the bone skeletal age is only close to 11 or 12, which means they are a late bloomer, right? Or say if this is a 11-year-old, it's close to about 11-year-old bone age, then the patient is, I don't know, like 14, sorry, the patient is 8 and the bone age is close to 11. That means that this is definitely advanced by more than 2 years. So it tells you an idea about what their chronological age is and what their actual skeletal age is. And you can kind of differentiate between advanced versus delayed um, bone age. So I saw this patient recently. So we're just going to start off with this question and kind of go over more puberty related stuff. So you're seeing a 15-year-old male, adolescent male, for lack of pubertal signs. Patient describes pubic hair growth for the past 2 years, but denies any increase in the size of the phallus or testicles. He is otherwise healthy with unremarkable past medical or surgical history. There is a family history of delayed puberty on the paternal side of the family. On exam, vital signs are normal. He's at the 25th percentile for height and 40th for weight. He is 10 or 3 for pubic hair, but testes are 3 cc's bilaterally, which I'll tell you is pre-pubertal. So what is the next best step? Does anybody want to take a guess? What do you guys think? So his family history of delayed puberty, he's 15, he's still prepubertal. Should we have expected to see some signs of puberty? Yeah, at 15, he should be finishing up or, just hopefully have started, but he's got no testicular development, right? So I want to see what his bone age is. I'd like to know if he's got a delay in his bone age, which would be um, consistent with his family history of delayed puberty. Maybe he's got constitutional delay of growth. Um, but, that's one way to kind of differentiate where we need to go. I don't give you a lot of information. So the first thing you want to do is get a bone age to see, does he have a delay, right? So that's exactly what we did for this patient. And it was normal at 14 years of age. It's not quite delayed if it's only, it depends on the age, but for him, for 15 at 14 years for his skeletal age is actually normal. So then we started thinking about what else could be going on with this patient, right? So let's jump into delayed puberty. So this is a lack of pubertal development. And this is delayed puberty is based on chronological age for boys. If they are over 14 years and have no pubertal development, that is considered delayed. And then for girls, it's 13 years. Okay. Um, also, if if they're having a lack of appropriate progression of puberty, these children are also referred over. And this is a girl does have thelarchy at the right age, but it's been 4 years since onset of thelarchy, and still has not had menstruation. That would be considered delayed. And then a patient is, say, 15-year-old, like the boy that I saw, and still is Tanner 2 on exam, which means he has started pubertal development, but he has not completed, and that's definitely also considered delayed. So differential, there's a couple of things that could be going on. These patients could have constitutional delay of growth and development, which is probably the most common thing that we see, especially in boys, and you'll definitely see it in general pediatrics as well. Secondary or functional hypogonadotropic hypogonadism, which we're going to talk more about. Primary hypogonadotropic hypogonadism, and then hypergonadotropic hypogonadism. So let's look at these in a little bit more detail. So constitutional delay of growth and development is where there's delay of pubertal development in otherwise completely healthy boy or girl, right? So these are the classic late bloomers. There's a family history. The dad didn't stop growing until like first year of college. Those are all helpful clues. It is diagnosed more often in boys, but that could be, we also see a lot more boys with it. Could be a referral bias, but definitely diagnosed more often in boys. Puberty, it does occur spontaneously, but later than average age, and it is a normal variant. And like I said, 50% of the cases, there's usually a family history. Um, these kids are born with normal length and weight at birth. There is a decline in growth velocity and weight gain from around 6 months to 2 to 3 years of age, right? Then growth follows a normal linear growth velocity, but at a lower percentile than would be expected based on family genetics throughout the prepubertal years. So, even though they're growing like at the fifth percentile, maybe, or, less than that, they are still maintaining that linear growth velocity up until puberty of like 5 centimeter per year or close to it. So that's your clue that there's most likely going to be constitutional delay. And then during puberty, if you were to see them, and we quite frequently see these kids during puberty, there's a decline in height percentiles because they are expected to go through puberty. So you're seeing this 12-year-old, 13-year-old, and you see that they are having a decline in height percentiles because there's a delay in onset of the pubertal growth spurt. And then there's slight slowing of linear growth before onset of puberty. So you really have to get a good history, look at the family history, look at your bone age to really make this diagnosis, because it's easy to mistake this for thinking, oh, they've got possibly growth hormone deficiency or some other organic etiology going on, but rather this is a normal variant, right? So what do we get? So usually I'd like to get a bone age because that's going to help me see that this patient does have a delayed bone age. So it's a lot more reassuring to get a 14-year-old male and see that the bone age is only about 11 or 12. That means that he has got longer time to grow and he's a late bloomer, right? If I were to get um, gonadotropins, which are FSH, LH, and then also testosterone, I would see that they're all prepubertal. And then height of the child with constitutional delay should be appropriate for his or her genetic target height. So let me tell you what I mean by that. So say if I'm seeing this patient at like around 14 and I get a bone age and it's about 2 years delayed. So that would put him around 12 for his height age. And then the midparental height is like around the 25th or 30th percentile. So as you can see, if he is around his skeletal age is around 12, that means that he is set to hit his genetic target, but much slower than his peers maybe. However, he does definitely reach where he's supposed to be based on his genetic target. So this is probably a classic curve for constitutional delay. Like you can see, they're kind of growing under the third percentile, but definitely maintaining that same linear growth velocity. And then somewhere around like 13, 14, if they start hitting puberty, and then you see acceleration and they end up exactly where they're supposed to be. Um, and, you know, yeah, um, definitely meeting the genetic target, right? So treatment for this, it takes a lot of reassurance. These parents and kids are, usually very upset that they're still not started puberty. We can go ahead and do a jump start with testosterone, especially if it's a 14-year-old, 14 and a half, and has had no signs and all his peers are growing and going through pubertal changes. I think that it's very reasonable to treat them with a short course of testosterone. There is some controversy over premature epiphyseal closure and reduced final height. I don't know how true this is. They usually a short duration of like 50 milligrams IM every 4 weeks for 3 to 6 months should really have no effect on final adult height. However, treatment for like 12 months to a year will probably lead to some effect on final adult height. And I don't know the exact, height percentile, height in inches that would be affected, but I would think that short courses would be totally reasonable to do in these kids. So we can offer jumpstart with testosterone and then usually just time. Okay. All right. So what about functional hypogonadotropic hypogonadism? So these are the children with chronic illness that have a delay in normal sexual development, right? They're poorly controlled either due to their underlying illness or they have an undiagnosed illness. Um, so if you identify and treat appropriately, usually this is reversible. So chronic illnesses such as recurrent infections, we have found 2 cases of inflammatory bowel disease because they're coming in with short stature or delayed puberty and have been having some abdominal pain, diarrhea. An investigation led to inflammatory bowel disease, immunodeficiency, congenital heart disease. We frequently see chronic kidney disease. These kids are um, also needing some help with treatment to go through puberty sometimes, and given the chronic nature of their illness, chronic anemias, endocrine disorders, eating disorders. So these kids, even if they do go through puberty, sometimes they may have delayed growth as well as a blunted pubertal growth spurt. The whole 25 to 28 centimeters that I told you, they may not always get to that. So it just depends on how long they've had that illness, how well it is being treated, how severe it is, um, and how compliant they are with treatment, I guess. So the etiology behind FHH is multifactorial, could be nutritional deficit. They could have increased energy expenditure, such as in children with CF, lung disease, infections, or other inflammatory conditions. So they could also have an abnormal growth hormone and IGF-1 axis. In chronic kidney disease, even if their IGF-1 is normal, they could have a little bit of resistance to growth hormone. Cystic fibrosis, and Crohn's disease. Um, they could have increased cytokines, such as in JIA. And frequently, what do we see? A lot of these kids with Crohn's disease or even JRA, they are on glucocorticoids, which suppress release of gonadotropins. So frequently see them with delayed puberty as well. What about endocrine stuff, right? So we do see, at least I would say every few months, severe untreated hypothyroidism presenting with delayed puberty, and also a growth hormone deficiency can also present like this. Also hyperprolactinemia. Prolactin is secreted by the lactotrophs in the anterior pituitary gland, which leads to decreased secretion of gonadotropins. And this could be male or female patient with delayed sexual development and presenting with galactorrhea. So definitely don't forget about hyperprolactinemia. I think in boys especially, we don't think about it, but they could definitely have hyperprolactinemia leading to lack of sexual development. All right. Cushing's, hypercortisolemia, so they can present with lack of pubertal progression. However, it could also present with precocious puberty. Very rare. I don't think I have seen this present. I'm following a patient with Cushing's who presented with precocious puberty. So close to this, they have easy bruising, the purple striae, acanthosis, definitely growth failure that you see with increase in weight gain. So just one of the things to keep in mind. So diagnosis for this, you're gonna need a really good medical history, look at the growth charts, see what the weight is doing, and then family history. If there's a strong family history of autoimmune conditions, definitely, think about that. Hopefully, physical examination will give you some clues, and then labs. So I think if we do get somebody and we're not, really having an idea of what it is, and they have some subtle symptoms, some abdominal pain, some occasional diarrhea, but really nothing that's jumping out at us. We do go ahead and get these labs, CMP, CPC, sed rate, um, screen for celiac, screen for hypothyroidism, just to see if we're missing something in these kids with delayed puberty. And treatment really is to treat the underlying diagnosis, right? So hypothyroidism, severe, untreated, usually normalizing the TSH should go ahead and induce puberty. I've seen a couple of children with CF and chronic kidney disease who needed help to go through puberty, just because of their chronic underlying disease, which probably isn't well controlled. So some of these patients, even when you treat the underlying diagnosis, they may need some help going through puberty, right? All right. So going back to maybe our 14-year-old patient or a 15-year-old patient who, had normal bone age at 14, has no signs of puberty, and obviously he meets criteria, and this should say by age 14 years in boys, but um, he actually ended up having low LH and FSH levels obtained at 8 a.m., as well as low testosterone levels. So we were thinking possibly congenital or acquired form of hypogonadotropic hypogonadism. So there's a lot of congenital forms. They could have kispeptin-1 gene receptor mutations. They could have isolated gonadotropin deficiency, the one that we always look for, and maybe something that you may see in board exams or shelf exams is Kallman syndrome. Say, the 15-year-old patient came in with delayed puberty and has a lack of smell or just decreased smell. Think about Kallman syndrome, and we'll talk a little bit more. Adrenal hypoplasia, which is congenital, pituitary transcription factor deficiency, and then also syndromes such as Prader-Willi syndrome, Charge syndrome, and Noonan syndrome. And then acquired are the ones that are due to, brain tumors, maybe suprasellar or sellar tumors. We frequently see craniopharyngioma, trauma or prior surgery to the pituitary gland, infiltrative disorders, such as granulomatous disorders such as histiocytosis, sarcoidosis, prior history of infection, meningitis. These kids could present sometimes with precocious puberty, but also could present with delayed puberty. So Kallman syndrome, like I said, it's decreased GnRH secretion. You have impaired GnRH and olfactory neuron migration. So they could have hypogonadotropic hypogonadism and a disordered sense of smell. They can present with cryptorchidism and microphallus. Pituitary transcription factor deficiency, there's quite a few, but the one that I probably have seen on board exams is mutations in the HESX1 gene. It's commonly associated with the septo-optic dysplasia. Um, they can have abnormal midline structures such as absent septum pellucidum, agenesis of corpus callosum, optic nerve hypoplasia. They could have pituitary hypoplasia. And these children can present with isolated growth hormone deficiency to multiple pituitary hormone deficiencies, including delayed puberty. And then Prader-Willi, this is loss of function of genes in the 15q11 Q13 region. They can have presentation consistent with microphallus. They have a narrow nasal bridge, downturned mouth. They usually have poor tone and failure to thrive as an infant, but then 2 years onwards, these are the kids that are developing polyphagia and increasing obesity. Noonan syndrome is gain of function mutation in the PTPN11 gene, and it can be seen in both males and females. They classically have the right-sided congenital heart disease, of which pulmonic stenosis is common. They could also present with short stature and then hypogonadotropic hypogonadism as well, because they have frequently cryptorganism or microphallus. And then Charge syndrome, um, autosomal dominant. They also could have olfactory bulb abnormalities, but they also have heart anomalies, choanal atresia, short stature, and then genital hypoplasia, ear abnormalities. So the reason I put all these is just so that, if you have somebody with hypogonadotropic hypogonadism, definitely think about syndromes too, as well as other transcription defects and acquired forms. So you definitely don't want to miss like a craniopharyngioma. So I did go ahead and get a brain MRI in my patient with the delayed puberty at 15, and it was completely normal with a prepubertal pituitary gland. So I think he may have isolated hypogonadotropic hypogonadism. And then if insurance would approve it, I would love to do some genetic testing, but we'll see how that goes. And then, so say you do get gonadotropins, and instead of being low, they are very high. So LH and FSH are extremely high, and then they have undetectable testosterone or estradiol, right? So you can see that the HPG axis is stimulated, but there's lack of negative feedback, so these LH and FSH levels continue to go up. So in boys, this could be congenital testicular failure. I've seen one kid with this, and they will need help with testosterone throughout their life. Klinefelter syndrome is common. Some of these kids could go through puberty normally, but then would present later on with infertility and low testosterone levels. Or they may need help even to have induction of puberty. And then you can also have acquired testicular failure. These kids could have had trauma to the testes, could be some sort of toxins, chemotherapy, or other toxins. And then orchitis, mumps virus commonly has been known to be associated with causing testicular failure. So Klinefelter syndrome, we do see this somewhat, I would say every couple of months. These are the kids who are presenting for maybe delayed puberty or gynecomastia. They have small testes, normal adrenarche, and then, but when you look at their testosterone levels, they are low to just on the low normal range, and then completely elevated FSH and LH. These kids also have an increased incidence of autoimmune disorders such as SLE, rheumatoid arthritis, and hypothyroidism, so something to keep in mind. And then in girls, the most common one that we see is Turner syndrome. So this is complete or partial absence of one X chromosome. They usually have streak ovaries, which are definitely not responding to the elevated LH and FSH levels. So you have undetectable estradiol levels in these girls. The only thing that they may present with sometimes is short stature, and that's how they come to attention. But they definitely have premature ovarian failure. They could also have webbed neck, cardiac anomalies, coarctations, bicuspid aortic valve. They may also have white space nipples, a white carrying angle, hearing deficits. So whenever you see a girl, 12, 13, white space nipples, short stature, history of maybe having some ear infections, but all you see is maybe just short stature, definitely think about Turner syndrome. It would, we certainly think about getting a karyotype or at least screening with some gonadotropins, because if you have a 12 or a 13-year-old short stature, and their insurance requires karyotype, with approval for karyotype, you can just go ahead and get FSH and LH, and if they already have failure at 12, 13, you can you could be sure that you're probably dealing with Turner syndrome. Right. And then acquired ovarian failure could be seen in autoimmune polyglandular syndrome 1, APS1. So this is one of those frequently asked questions probably on board exams. This is an autosomal recessive disorder. It's due to mutations of the AIR gene. They can have chronic mucocutaneous candidiasis, hypoparathyroidism, adrenal insufficiency, but also gonadal failure. They could also have other conditions such as vitiligo, atrophic gastritis, and chronic hepatitis. So the treatment really for hypogonadotropic hypogonadism and hypergonadotropic hypogonadism is obviously depending on a boy or girl, but it's testosterone and estradiol. For testosterone, we usually start off slow with injections and then build it over the next 2 years to 3 years and help them go through puberty. So you're basically inducing puberty. And then with estradiol, there's a couple of options, but really transdermal is the best because you can choose the doses very carefully and start with the lowest possible doses. And usually, we do use transdermal for the girls. And again, same things. You start off slow and get them through puberty. And then once they reach menses, then you can probably switch them to an oral contraceptive pill depending on what they want to do or a different form. But treatment is the same. Okay, so let's switch gears a little bit. What about the other end of the spectrum, right? So you're seeing a 5-year-old female for concerns regarding precocious puberty in clinic. On exam, she is growing steadily at the 25th percentile for both height and weight. No recent linear growth acceleration. Patient is Tanner 1 for breast development. She is Tanner 3 for pubic hair. No clitomegaly. Vaginal introitus does not appear estrogenized. She's otherwise healthy with no known exposure to testosterone-containing creams, and she has a normal bone age on evaluation. What is the most likely etiology? What do you guys think? All right.
Premature adrenarche.
Exactly. I was going to call on you, Alyssa. Right. So this does not really scream adrenal tumor or non-classical congenital adrenal hyperplasia, right? And it's not central precocious puberty because she does not have breast development. So let's take a look at benign premature adrenarche, and then we'll talk a little bit about actually precocious puberty, central precocious puberty. So in benign premature adrenarche, they have they just have evidence of maybe pubic hair, body odor, acne, and then oily skin, but they should not have any evidence of linear growth spurt, increase in muscle mass, waist deepening, or male pattern baldness. In girls, you should not see any clitomegaly, and then boys should not have any penile enlargement. If you're seeing any of those, you're probably dealing with something more organic, like maybe an adrenal tumor or non-classical congenital adrenal hyperplasia. And they also should not have any sign of thelarchy or testicular enlargement. These children usually have a normal bone age, which is basically either completely normal or like could be 1 to up to 2 years advanced, but it's not significant. Right. So in these children, we typically want to rule out, say we do get a bone age and it's advanced, or we do see that maybe they have some sign of virilization. significant increase in acne, some linear growth acceleration, any of those that don't quite fit with benign premature adrenarche, I do go ahead and get blood work to rule out non-classical congenital adrenal hyperplasia, an adrenal tumor, maybe get some imaging to rule out ovarian tumor, and then obviously true central precocious puberty. There's no treatment indicated for benign premature adrenarche. You don't have to stop them from progressing through this, and you know, it should not alter the timing of actual puberty as well. And then there is some data on um, increased risk of polycystic ovarian syndrome for these children in the future. But I usually just say, concentrate on eating healthy and don't really go a lot into PCOS because that's down the road. And a lot of factors could change in terms of their weight and, insulin resistance. So we mention it, but, we don't necessarily follow these kids to see if they develop PCOS. I talk about evaluation. No. So, all right. So, lab evaluation, I usually, if I am concerned, bone age is advanced, I do like to get a 17 hydroxyprogesterone to rule out non classical CAH, a total testosterone, and DHEAS. The DHEAS helps me rule out possibly any adrenal tumor, or say if the testosterone is like 150, I'm definitely going to be looking at, any adrenal tumor or also an ovarian tumor as well. Okay. So what about actual central precocious puberty? So this is gonadotropin dependent. This is initiated by pulsatile GnRH secretion, frequently seen more often in girls than boys. And then what's the criteria? Girls less than 8 years of age, if they have signs of puberty, that's early, and then boys less than 9 years of age. Of course, timing of puberty is dependent on many factors, including we've talked about, family history plays a role. There be think BMI these days is causing children to go through puberty a little bit earlier than maybe a couple of decades ago. And then possible endocrine disruptors in the environment. So, what is the initial sign of puberty? So, we frequently see this where, they have pubic hair, it gets sent over urgently at like 5 or 6 years of age for central precocious puberty. But really, the first sign of puberty in girls is thelarchy. Thelarchy, yes, but actually, maybe the first sign is ovarian enlargement, and we can't really see that unless we get a pelvic ultrasound. So in girls, the substitute is thelarchy, and in boys, it's not pubic hair or anything else. It's actually testicular enlargement. So there's a couple of things, keep in mind when they show up at 2 or 3 years of age, got bilateral or, asymmetric thelarchy, anywhere from birth to 2.5 years of age. This is just benign premature thelarchy in most of the cases. About maybe 10 to 15%, you know, uh, may progress to central precocious puberty, and definitely follow up is important. But a lot of times this is very common. So we frequently see this referral, and they're always getting gonadotropins in these kids. But this is actually very common. And then it's actually very easy to misdiagnose these kids as having central precocious puberty if you get FSH, LH during the first year of life, because they're actually going through a period called mini puberty of infancy, where their gonadotropins are actually in the pubertal range. So if you get a 9-month-old and the pediatrician is concerned, they've got bilateral thelarchy, they're getting bigger, I'm going to get pubertal hormones, puberty hormones, and they're elevated. So I think that a lot of times, unless there's other things going on, linear growth acceleration, there's advancement in skeletal age, you you want to be very cautious in making that diagnosis. I think this is one of those really tough ones if you get levels and um, you think it's probably just benign premature thelarchy. One of the clues is, if you get LH and FSH, LH may be kind of prepubertal, but they have an elevated FSH. So this is a FSH predominant response in these kids, and all they need is reassurance, and there's no treatment indicated. But so say, it's a 5-year-old and have bilateral telarchy. Yeah, so that's GnRH dependent, called central precocious puberty. In girls, like I said, it's frequently found compared to boys, and 80% or maybe even higher, I would say, in clinical practice are idiopathic. In boys, if you have a 5-year-old presenting with precocious puberty, there's a 90% chance there's something going on. Only 10% of cases are idiopathic. So if you were to see a 8-year-old, 7-year-old with boys, we are more apt to image those kids or do further investigation versus say like a 7.5-year-old girl presenting with precocious puberty. So pathological causes are hypothalamic hamartomas, other brain tumors, craniopharyngiomas can also cause precocious puberty, rachis hydrocephalus, optic nerve hypoplasia, neurofibromatosis 1, and then untreated peripheral causes of puberty. So this is, say, for example, they have non-classical congenital adrenal hyperplasia, and they were very non-compliant. So they have all this testosterone running around. That can set off central precocious puberty. So that's why it's very important to adequately and appropriately treat these kids. So diagnosis is obviously, like I said, we always get a bone age, right? So get the bone age. If significantly advanced, you start your workup. You want to measure basal levels of LH, FSH, estradiol, and testosterone levels, preferably 8 a.m. fasting. And if you are convinced they are pubertal, but your levels are not consistent, you could do a GnRH stim test and say that does confirm that they are in puberty. Then you want to get an MRI of the brain to obviously evaluate for any evidence of tumors. You can also get an idea of a pituitary height. Over a certain height could be considered pubertal versus prepubertal. And then if there's still some doubt, you get a pelvic ultrasounds. There are measurements on how big the ovaries are, and that could kind of help you differentiate prepubertal versus pubertal, and then also look at for endometrial lining. So there's frequently debate on, so why treat? Obviously helps to preserve adult height. After a certain bone age, though, really it's not so much preservation of adult height, but rather psychosocial concerns of having to start cycle like in first grade or second grade, or the boys started very early and showing signs of aggressiveness or anxiety. So multiple reasons, but ultimately there's, if I had somebody yesterday who say, I'm not going to treat my girl without anything just because of height. So I don't know if they'll change their mind, but there's no medical cause. So we're not treating say a hypothalamic hamartoma or something with stopping puberty. Stopping puberty because we are worried about their adult height and then psychosocial concerns. So GnRH agonists actually work because remember I said precocious puberty is gonadotropin dependent. It starts with GnRH secretion in a pulsatile manner. So if you give a GnRH agonist and it's a depot, so it's a prolonged duration of action. So that downregulates pituitary GnRH receptor. So you prevent responsiveness to GnRH to decrease LH and FSH secretion. So there's multiple options. There's injections, implant, depending on what the family wants to do, and insurance dependent as well. You are looking at your clinical exam, confirming with the prepubertal gonadotropins while they're being treated. You can get a bone age to make sure that it is either stalled and not progressing. And then hopefully, remember I told you what the linear growth velocity is like in puberty, right? So hopefully they have slowed down and hopefully, um, are growing at a prepubertal rate. And then, are they less irritable? Are they less moody? All of that is a good way to see and gauge how your treatment is working. And then treatment discontinuation is kind of personal. Depends on what the family wants to do, but usually around 11 years old for girls and 12 years for boys. And then usual pubertal development and progression starts about 6 months to 12 months after you stop treatment. So you do have a little bit of time before, say if they were menstruating before, you still have time after you stop. And then what about precocious pseudopuberty? So this is not related to activation of the hypothalamic pituitary gonadal axis. This is all driven by hormones being released by the gonads or adrenals. Um, and then in girls and boys, they have premature androgen production, signs of virilization, and a significantly advanced bone age. Um, there's, there's lots of etiologies. Could be non-classical congenital adrenal hyperplasia, like I said. Girls could present with ovarian tumors. Boys could be Leydig cell tumors. We did see recently a 7-year-old who had a bone age that was advanced to like 12 with completely suppressed FSH, LH, and the testosterone was like in the hundreds, which is very elevated. So when we got a testicular ultrasound, he had uh, a mass in his right testicle, which was consistent with Leydig cell tumor on pathology. So treatment was to take out um, you know, the mass, and his testosterone levels normalized very nicely. And then familial testotoxicosis, kind of similar presentation, but it's genetic in etiology. It's LH receptor mutation. There's constituent activation. So they also present with undetectable LH, FSH, and very elevated testosterone levels. So diagnosis, obviously bone age, you're looking at getting imaging depending on what levels are elevated. If you have a significantly elevated DHEAS, maybe you're missing a, adrenal tumor. So think about getting adrenal imaging, Leydig cell tumor, so testicular ultrasound, or, elevated testosterone in a girl, and you're going to get a pelvic ultrasound or an MRI to better visualize the ovaries, right? Treatment really depends on etiology. So it's different based on where it's coming from, what part, is it adrenals? So I won't go into detail with that, but it depends on etiology. All right, so what if I told, this is from Wikipedia, and I didn't want to put the source because I don't want to give it away, but this is say a 6-year-old female who has this, lesion on her and has fluctuating breast development and vaginal bleeding, and you are evaluating her for precocious puberty. And I'll tell you on exam, or on evaluation, she has undetectable FSH, LH, but her estradiol is elevated. What do you guys think is the diagnosis? You always ask for, do they have any?
Is that making an ovary?
Yes, exactly. Who said that?
Alyssa.
Alyssa, hey. All right, so you are picking up all these things, right? So yeah, so this girl has McEwen Albright's. I have not seen, it's actually a really hard diagnosis to make because the levels of estradiol are fluctuating, and it's rarely, of course, comes in classic, precocious puberty and CAF-LA and polycystic fibrous dysplasia, but when you do, it's the classic triad, and these girls could have, girls or boys, but that's a girl, so she could have fluctuating breast development and have vaginal bleeding. So, um, and I've definitely seen this on board exams, so, to keep this in mind, make you an Albright. And that's all I have. Do you guys have any questions about either delayed or precocious puberty? No questions? All right, then I will see you guys later, and call me, email me if you guys have any questions about this presentation. All right, thank you.